Good evening, consultants on the call, fellows and colleagues. We welcome you to today's presentation and also MCQs revision. Today we are presenting on ventricular arrhythmias, and we have Dr. George Adams Ofosu to lead this discussion. Dr. Ofosu, please, your audience.
All right, thank you, Eugene. And good morning, consultants. Good morning, good evening, fellow colleagues. I hope I can be heard clearly.
Loud and clear, please.
Okay, thank you. So this evening, my task is to take us through pathophysiology of ventricular arrhythmias, but I'll go a little beyond the scope of the topic. Okay, so this will be my outline. We'll look at the normal conduction system, an introduction, and then the various forms of ventricular arrhythmias, premature ventricular complexes, ventricular tachycardia, ventricular fibrillation, ventricular flutter, and then we'll end with electrical storm. So on the screen, we have the normal electrical conduction pathway of the normal heart. So at the top here, between the right atrium and the superior vena cava junction, where the two meet, we have the sinoatrial nodes, and then we have the anterior internal nodal tract, middle internal nodal tract, posterior tract, and then the Bachmann's bundle. So impulses from the SA node passes through these channels and eventually ends at the AB node, and then goes to the bundle of His to the right and left bundle branches. Further goes to the Purkinje fibers to activate both ventricles. So when current goes to this channel with no interruptions, then it gives us a normal P wave, a KRS complex, which is narrow, with a duration which is less than 1.2 milliseconds. Let's say 120 milliseconds, and then a T wave. So by way of introduction, ventricular tachycardias refers to any arrhythmia that is faster than 100 beats per minute, which arises distal to the bundle of His. It is the most common form of a wide complex tachycardia and has a high mortality rate if nothing is done to halt it. Ventricular arrhythmias originate in the ventricular myocardium or His Purkinje system, or both the ventricular myocardium and the Purkinje system. We have various forms. We have the premature ventricular complexes, non-sustained ventricular tachycardia, sustained ventricular tachycardia, ventricular fibrillation, also ventricular flutter. It occurs in all forms of structural heart disease that involves the ventricles and can also be an initial presentation of the disease. Sustained arrhythmias are an important cause of sudden death, and some genetic abnormalities of cardiac ion channels can cause sudden death from ventricular arrhythmias, despite the absence of structural heart disease. So we have what we call the idiopathic ventricular arrhythmias, and these are ventricular arrhythmias that occurs in the absence of a structural heart disease and a defined ion channel abnormality. So owing to the severity of this condition and its high mortality, if nothing is done, evaluation and management are guided by symptoms and underlying heart disease and the risk of arrhythmic sudden death. And because of the differences in prognosis and treatment option, proper diagnosis has to be made, and we need to know how to differentiate all the forms of ventricular arrhythmias, which we'll look at in subsequent slides. So first, we are going to start with premature ventricular complexes. How do we recognize this on an ECG? So basically, a PVC is characterized by premature occurrence of an abnormal KRS complex. That usually has a duration that exceeds 120 milliseconds, or 3 small boxes on the ECG paper. When you have a PVC, the corresponding T wave is typically broad and in opposite direction to the major KRS complex. So usually the major KRS complex is in the positive direction, the T wave will be in the negative direction and vice versa. Typically, it is not preceded by a P wave. So by way of image, this is how a PVC looks like. So here we have a PVC, another one, and a third one. So by definition, it has to be a broad complex. And by broad complex, we mean carries duration of more than 120 milliseconds. It should have no preceding T wave. So here, what you have here is a T. You cannot see any P wave. And the KRS, the T wave that follows the broad KRS complex is usually wide as compared to the other KRS complexes. And it's in the opposite direction of the KRS. So PVCs are due to abnormal impulse formation, which may be due to automaticity, triggered activity, or re-entry in the ventricular myocardium or the Purkinje system, which produces a depolarization wavefront that propagates to the ventricle. And this happens independent of activation from the sino-atrial node or the AV node. The actual mechanism cannot always be determined with certainty. Premature atrial or junctional beats that occur with a bundle branch block can sometimes mimic a PVC, and we need to be able to differentiate this from an actual PVC. So on this ECG tracing, if we look at the first arrow, what we see is a premature atrial complex. That is this one, which is followed by no QRS complex. And then the second one is actually a PVC with aberrancy, or a PVC mimic. If we look at this, it looks broad, just like we described earlier on. It's the opposite direction. But what makes the PVC aberrancy? Okay, thank you. So what made this PAC with aberrancy is the fact that it has a preceding P wave, which is an abnormal P wave. And then the QRS complex is usually of right bundle branch morphology. So this is a PAC with aberrancy, but not a PVC. So it is not, or PVC is not always pathologic and can be found in normal adults with up to 500 PVCs occurring in 24 hours in an adult can be considered normal. And PVCs are identified on a standard ECG in up to less than 1% of individuals younger than 20 years. And this increases with age to more than 20% of PVCs being present on an ECG in older adults who are more than 50 years. PVC also increases with age and also increases as an individual has a lot of cardiovascular risk factors such as hypertension, obesity, and smoking. So this one is a video. Unfortunately, the sound does not play, but it's just showing the normal hearts, the conduction system. So we can see the SA node firing, causing the atrium to contract. The AV node being activated, the impulses going through the right bundle through the left bundle in a normal heart, and the heart is contracting normally. So what we are seeing now is a PVC, which is being fired in the left ventricle and causing abnormal contraction of the left ventricle. Okay, so what are some of the risk factors of PVC? One of the most common risk factors is ischemic heart disease. We have heart failure, cardiomyopathies. It's also common in patients with increased adrenergic tone. An increased adrenergic tone usually occurs in acute illness. Patients with anxiety, patients who have taken stimulants, and also patients who have taken beta agonists, they usually have increased adrenergic tone, and that makes PVC common in this group of patients. Also, electrolyte abnormalities, and it's commonly found in hypokalemia, hypomagnesemia, and patients with hypertension and smoking, obstructive sleep apnea, and also advance in age. So PVC most often doesn't come with any symptoms, but if it does, the most common symptom that it presents with is palpitations. And these palpitations are usually perceived by the patient as strong beats. And matter that this strong beats is not actually from the PVC, but it's they perceive the strong beats from the sinus beat that follows the PVC. So usually when you have a PVC, you have a pause after the PVC, and this prolonged the filling time of the ventricles. So the beat that follows the PVC will actually be stronger than the subsequent beats. That is what the patients usually experience as the palpitation. They also present with lightheadedness, weakness, fatigue, and occasionally they may have chest pains, syncope. And when these three symptoms are present, that's the chest pain, syncope, and syncope, it's an indication of a much serious cardiac obstructive heart disease. So how do we classify PVCs? So it can be classified based on the morphology as seen on the ECG, also the pattern as seen on the ECG, and the timing of the PVC, which reference to the normal TRS complexes. So in terms of morphology, PVCs with a single TRS morphology are referred to as unifocal beats. And those with different TRS morphologies are referred to as multifocal or multiform PVCs. And multiform PVCs usually indicates the fact that there are more than one focus that is firing to produce the PVCs. Frequent multifocal PVCs are more often associated with structural heart disease. So the first picture showing is that of a unifocal PVC. So you can see 3 PVCs, and all 3 are of the same morphology. The next image is showing a multifocal PVCs. So we can see one PVC here, which is predominantly positive. Another one, which is predominantly negative. So they are of different morphologies. So that's a multifocal PVC. PVCs often occur in repeating patterns. And by these patterns, we have various forms. We have bigeminy, and in bigeminy, every other bit will be a PVC. We have trigeminy, which every third bit is a PVC. Quadrigeminy, where every fourth bit is a PVC. And couplets. Couplets is when PVC occurs, two PVC occur in succession or consecutively. We also have triplets, when you have three PVCs occurring consecutively. So this one shows a bigeminy. Okay, so here we have normal KRS complex followed by PVC, then a normal KRS complex, PVC, normal KRS complex. So alternating normal, every other bit is a PVC. So the normal KRS complex alternates with a PVC. Trigeminy, every third bit is a PVC. So you have two normal bits and a PVC, two normal bits and a PVC. So that's the trigeminy. And then we have the quadrigeminy, where every four bits will be a PVC. So if you look at it from here, we have normal bits, normal second bit, normal third bits, followed by the PVCs. And the trend will continue. Here we have the
Yeah,
Eugene.
yeah, you can see. You can go ahead.
Yes, sorry about that. So we'll continue from the pattern. So this is a couplet where you have two PVCs occurring in succession. And that's the triplets. So you have three PVCs occurring together, followed by normal KRS complexes. So PVC can also be classified based on the timing, by which time the PVC occurs with reference to the normal KRS complexes. So the timing of PVC and its interference with the conduction system determines the effect on the rhythm. And often PVC excitation waveform propagates retrogradely in the His-Packinger system. So by timing, we have a compensatory pulse. With this one, the PVC collides with the sinus impulse, either in the AB node or the conduction system. So as we know, PVC originates from the ventricle or below the bundle of His. It stimulates the ventricles to contract and may go backwards in the conduction system. So as it's going upwards, it may collide with a normal sinus rhythm that is coming downward from the SA node. And when that happens, it creates what is called a compensatory pulse. So the PVC fails to reach the atrium and has no effects on the sinus node automaticity. That's when it collides with the oncoming sinus impulse. So when this happens, the next sinus beat will be on time, resulting in a compensatory pulse with R to R interval from the sinus beat preceding the PVC to be preceding the PVC to the one following the PVC equals to twice the sinus cycle length. Okay, so that can be seen on this ECG. Get my pointer. Okay, so this is the normal beat that is coming from the SA node, and we have a PVC. So when the PVC occurs, the ventricle contracts, giving this wave, and the same impulse goes backwards towards the AB node and the SA node. And when it collides with the oncoming impulse from the SA node, it prevents it from showing here. And the impulse doesn't get to the SA node to cause an interference with the next normal beat, which shows here. So this gap is what is called the compensatory pulse. And usually, if you measure from the R wave before the TVC to the R wave after the TVC, that distance will be about twice the R to R interval preceding the PVC. So that is what is demonstrated here. From this point to that point, it's about half the distance between this QRS complex and the one following the PVC. So if the PVC conducts to the atrium, the retrograde T wave is usually visible on the QRS at the end of the QRS complex. And the retrograde T wave can then reset the sinus node, producing an incomplete compensatory pulse, in which is more commonly associated with premature atrial beats. So here we are seeing what is called the incomplete compensatory pulse. So in this one, the PVC is able to conduct retrogradely and gets to the sinoatrial node, causing a reset. And after the reset, the following QRS complexes, the following QRS complex occurs a little earlier. So if you measure the RR interval between the QRS complex before the PVC and the one after, it's a little less than 2 times the regular RR interval. Okay, so it can also, these can also be classified according to the timing. That is according to when the PVC occurred. So with that, we have fusion beats. And fusion beats is like a hybrid beat between a normal beat and then a PVC. So if PVCs are relatively late in the cardiac cycle, the PVC activation waveform may collide with the sinus waveform that has already reached the ventricles, producing a fusion beats. And fusion beats are common and are characterized by a short RR interval and an intermediate QRS complex that is similar in shape to an ectopic ventricular complex and a normal QRS complex. So on this ECG tracing, what has been highlighted is what is referred to as a fusion beat. Okay. Again, by way of timing, we have what is called interpolated PVC. This is basically a PVC that occurs and does not interfere with the normal heart rhythm. So a PVC can also fall between sinus beats without disturbing the AV conduction and without producing a pulse. And this is defined as interpolated PVCs. So by way of location, QRS morphology for PVC can also reflect the origin within the ventricles. So the wide QRS complex is due to the initial activation of the ventricles by the waveform propagating through the ventricular myocardium or part of the Purkinje system, rather than simultaneously through the right and left bundle branches. And the ventricular activation sequence is largely determined by the site of initial ventricular activation, and hence the QRS morphology is an indication of the location of the ventricular arrhythmia origin. So usually if you have a right ventricular or interventricular septum origin, you have an LVV pattern PVC. And this one will have a dominant S in V1 and usually termed as a left bundle branch like, and it generally originates from the right ventricle or interventricular septum. So if you have a site that is generating these impulses, and the site is in the right ventricle, ideally it will depolarize the right ventricle first before going on to depolarize the left ventricle. And this will mimic a left bundle branch block. So if you always see a left bundle branch block pattern, which will usually show as a dominant S in V1, then it's most likely that the PVC is coming from either the right ventricle or the interventricular septum. And those of left ventricular origin will have a dominant R wave in V1, and they are termed right bundle branch block-like, and they generally originate in the left ventricle in a morphologically normal heart. PVC can be produced by direct mechanical, electrical, or chemical stimulation of the myocardium, and often noted during acute coronary syndromes, myocarditis, hypoxia, and electrolyte abnormalities, particularly in hypokalemia. Suggested mechanisms of PVC are re-entry, triggered activity, and enhanced automaticity. So this one, we heard a lot about it yesterday, but I'll talk more on it on subsequent slide as well. So what are the clinical significance of PVC? We should note very well that this can occur in healthy individuals, and PVCs that occurs less than 500 times in 24 hours can be considered normal if there's no other underlying heart condition. It's often asymptomatic. During exercise testing, 7 or more PVCs occurring per minute, either before or during exertion or during recovery, can occur in fewer than 10% of patients who have no history of heart disease. Exercise-induced arrhythmias can also be associated with underlying structural heart disease or be a manifestation of a rare genetic arrhythmia syndrome, particularly catecholaminergic polymorphic VT. And again, exercise-induced PVCs and non-sustained VT have been associated with increased morbidity during long-term follow-up. And benign idiopathic arrhythmia often originates from the right ventricular outflow tract. So physical examination usually reveal pulses that are often compensatory and do not disturb the expected rhythm of the pulse. And usually on physical examination, one is not able to palpate the PVCs, even though you may feel an irregular pulse. The actual PVCs will not be palpated. And this is due to the fact that stroke volume of the PVC is often insufficient to produce a palpable pulse. But the premature heart sounds are commonly audible to auscultation. Frequent PVCs may effectively produce bradycardia. And this is because I said earlier, the PVCs cannot be palpated. So when they are frequent, then only a few beats can be palpated. Again, you may have a Canon A wave being present in the JVP when the atria contracts during ventricular systole of a PVC. So how do we manage PVC? The importance of PVC depends on the clinical setting. So this actually depends on the patient's age, patient's comorbidities, and then patient's presenting symptoms, and then clinical examination findings, whether they have underlying heart disease, underlying structural heart disease, or without any structural heart disease. And always initial evaluation focuses on determining whether the PVCs are an indication of an underlying structural heart disease or electrical heart disease. Symptoms of near syncope or angina chest pain, and also dyspnea will usually warrant evaluation because this may be due to episodes of VT or other underlying heart diseases. And physical examination usually focus on eliciting signs of an underlying heart disease in a patient who is presenting with a PVC. So usually a 12-lead ECG should be done, and this is aimed at confirming the diagnosis and also helps to assess the origin of the PVC. And ECG abnormality usually warrants a further investigation to assess the LV function and also investigation to exclude coronary artery disease in those who are at risk. So in doing this, one will have to do an echocardiogram and also to consider an exercise stress test. And consideration of genetic ion channel abnormalities are also important. Okay, so we'll move on to ventricular tachycardias. So VT is any heart rate that is more than 100 beats per minute with 3 or more irregular beats in a row, arising distal to the bundle of His. And VT is the most common form of wide complex tachycardia and is associated with a high mortality rate. It is often caused by myocardial ischemia, structural heart disease, congenital heart disease, and also electrolyte derangement. And individuals may present with chest pain, dyspnea, palpitation, syncope, and sometimes hemodynamic instability. Diagnosis is usually based on characteristic ECG findings of a wide complex fusion or capture beats, and management requires antiarrhythmic medications or electrical cardioversion to avoid complications such as heart failure, multi-organ failure, and cardiac arrest. Its causes, the most common of them is the presence of a structural heart disease, ischemic heart disease, non-ischemic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy. All these can disrupt the normal conduction pattern, which may lead to a ventricular tachycardia. Congenital structural heart diseases and surgical scars can also contribute to a VT. So example of such cardiac disease may be pathology of Fallot or its associated surgical scar. Channelopathies are also cause of VTs, and inherited channelopathies such as long QT syndrome, short QT syndrome, Brugada, and cardiopulmonary polymorphic VT, and all increases one risk of developing a VT. And acquired channelopathies, most commonly from drugs that prolong the QT, example being class 1A and class 3 antiarrhythmic drugs, phenothiazines, and methadone are all important causes of ventricular tachycardia. And drugs that slow myocardial conductions, such as plecanide, propafenone, and halothane, can also promote re-entrant ventricular tachycardia. Electrolyte imbalance, usually hypokalemia, hypocalcemia, hypomagnesemia, and sympathomimetics such as IV inotropes. Also, illicit drugs such as cocaine and methamphetamine can all trigger ventricular tachycardia. The Italis or the digoxin toxicity can lead to biventricular tachycardia. Against other systemic illnesses that cause infiltrative heart disease, this commonly happens in sarcoidosis and amyloidosis. We also have SLE and hemochromatosis causing VT. Again, exposure to extreme temperatures, so extreme heat or cold, increases one risk of a VT or a VF. And this usually happens in patients with pre-existing cardiovascular disease. So these two tables are quite busy, but it's basically showing etiologies of VT, the cardiac structural abnormalities that are common, what we find when we do an ECG, and the features of VTs in such etiologies, and the usual initial management. So I'll skip these slides. We can look at them later. So how do we classify VT? Again, VTs can also be classified based on their duration, their morphology, mechanism of action, anatomical location or the site of origin, and clinical stability of the patient. So based on the duration, they can be classified as either non-sustained VT or a sustained VT. And a sustained VT is when you have a run of 3 or more consecutive ventricular beats that persists up to 30 seconds. That is a non-sustained VT. Or sustained VTs are those that persist more than 30 seconds. And based on the morphology, we can classify VT as either monomorphic VT, which is the most common. So in this VT, you can see that all the TRS complexes look the same throughout. That's monomorphic VT, and that's the most common. And then we have polymorphic VT. So you have VT of different morphologies. Some are predominantly positive, others negative. We also have a third one, which is very uncommon. That's the pleomorphic VT. So with this, we may have at least two morphologies, which keeps alternating. So here you can see all these groups are the same morphology and flowing by another VT of a different morphology. And these two morphologies keeps alternating. That gives what is called a pleomorphic VT. Again, we have to start the point, which means twisting around the point. And this is usually seen in patients with prolonged QT interval. The way we can identify this is you see the ventricular complexes of different lengths, and you get to a point when it becomes almost non-existent, and the start cycle starts all over again, as if the paper is being twisted at a particular point. So that's to start the point. Again, still on morphology, we have what is called a bidirectional VT. So in this form of VT, you usually have TRS complexes of two waveforms that keeps alternating. So here we have this one that is positive, then a negative one, followed by a positive and another negative one. But they are of the same morphology, is that they keep alternating between positive and negative. That's bidirectional VT. And this is usually seen in digoxin toxicity. Again, VT can be classified based on the mechanism by which it's occurring into re-entry, increased automaticity, and triggered activity. So re-entry is a common mechanism where an electrical impulse circulates repeatedly within a region of the ventricle, and is usually due to scarring from a previous MI. The scar tissue usually will disrupt normal electrical pathway, creating areas where impulses can loop back and re-excite the same area repeatedly. So usually when there is a scar tissue, the scar tissue conducts impulses at a much slower pace than the normal tissue. So we'll use this cartoon to explain how the re-entry happens. So this will be like a revision because this was done yesterday. So we'll consider A and B as two different pathways. The A pathway is the slow pathway, and then the B will be the fast or the normal pathway. So if you have impulses coming from the top, where it's labeled as I, when it gets to this point, the impulses goes through both the slow and then the fast pathway. And the slow pathway has a shorter refractory period, while the fast pathway has a longer refractory period. So when the impulses gets here, it goes through both A and B, but in a normal circumstance, it will go through the B faster and be able to cause a stimulation of the ventricle. So by the time the impulses goes through the A and gets to this point, it will still meet the fast pathway in the refractory periods, and the impulse from the slow pathway will be terminated. So this is what normally happens. We can also, when the PVC, what causes the PVC is the fact that you may have an impulse coming from the top here, and then it goes through the slow, the PVC. By the time it gets to this point, may find the slope pathway refractory, since it has a short refractory period, may find this A pathway refractory. So there's impulses will go through the slow pathway and cause the stimulation of the myocardium. At the same time, goes up through the fast pathway, and it's likely to meet the fast pathway in the refractory period. So that gets terminated. And this leads to what is termed the PVC. And for the re-entrant mechanism to occur, the impulse coming from the top may occur early enough. So it goes through the slow pathway, gets to this point, and still finds the fast pathway in the refractory states. Out of the refractory state, sorry. So it may go down to activate the ventricle and go up again, and may go all the way to activate the atrium, and then goes back into the ventricle. So this forms like an ending loop. So the impulse keeps going round within a small circle. And that is what is referred to as the re-entry. And we have abnormal automaticity. So in some cases, VT arises from an enhanced automaticity, where the cells outside the normal conduction system start generating impulses on their own. And this can occur even in structurally normal hearts. Triggered activity involves abnormal responses to stimuli that leads to premature contractions and can initiate a VT, especially in conditions like a long QT syndrome. So in the clinical settings, usually EP physicians will classify these mechanisms into two groups as either being re-entry or focal, and whereby the focal consists of the increased automaticity and then triggered activity. Scar tissue-related VTs actually associated with structural heart disease. They are primarily of the re-entry mechanism. They occur usually in older patients, and they relatively have poor prognosis as compared to idiopathic VT, which is associated with patients with no structural heart disease. And they are usually of focal mechanism. They occur in with one that's occurred from SCAR-related VT. Okay, so on the classification of VT, it can be classified based on patient's clinical stability. So by this, you may either have a hemodynamically stable VT or hemodynamically unstable VT. So patients with hemodynamically unstable VT may present with hypotension. They may be dyspneic. They may have altered level of consciousness. So they may present with confusion or lethargy. They can sometimes present with chest pain, pallor, diaphoresis, tachypnea, or cold, clammy extremities. So if you examine a patient and she has any of these symptoms, then the patient is classified as being hemodynamically unstable. And this has influence on the path of management. So by way of anatomic location and the site of origin, to classify VT, usually we need to ask ourselves three main questions. The first question is whether the R wave in V1 upright or down going. That's whether it's an LBB or of an RBB morphology. Secondly, is lead one upright or down going? And thirdly, are the inferior leads upright or down going? Okay, so for the first question, is the R in V1 upright or down going? So if you have an upright wave in V1, which gives morphology, right banded branch morphology, it's an indication that the site of the VT will be in the left ventricle. And if you have a downgoing or predominantly S wave in V1, it's also an indication that the origin will be in the right ventricle or the septum. If we come to V1, as we know, V1 is on the left side of the patient. So if you have an upright going QRS complexes, what it means is that the impulses are going towards V1 or going towards the left side or the left arm of the patient. And that will mean that the impulses will be coming from the right side. So that will be mainly septal in origin. And if the QRS complex in V1 is downgoing, as we are seeing here, that means that the impulses are moving away from V1. So then the location will be on the lateral side or the apical side. And then we come to the inferior leads. So the inferior leads, if they are predominantly positive, it means the impulses are moving towards the foot. So then the location of the site of the impulse will be at the anterior part of the heart. And then if the QRS complexes are predominantly negative, means the impulse is moving away from the inferior leads. Sorry, moving towards the inferior leads. So the lesion will be in. Let me take this one again. So if the impulses leads.
In a way. Inferior to the anterior side.
This shows a summary of what has been explained in the previous slide. Okay, so this algorithm is quite busy, but it has a lot of important information in making a diagnosis. So if you have a QRS complex that is different from the normal QRS complexes, the first step is to decide if the QRS complex is narrow or wide. So if the QRS complex is narrow, Then you come to this side. So are the KRS complexes regular or irregular? So the KRS complex is narrow and regular. Then this will be the possible differential diagnosis. May either be a sinus tachycardia, physiologic sinus tachycardia, inappropriate sinus tachycardia, AP, NRT, focal tachycardia, and the rest. However, if it's a narrow KRS complex but irregular, then the most likely differential is atrial fibrillation, multifocal atrial tachycardia, focal tachycardia with a variable AV block, atrial flutter with a variable AV block. And on the right side or left side of the screen, if the KRS complexes are wide, then you need to ask yourself, is it regular or irregular? If the KRS complexes are regular, then you have these as the differential diagnosis: monomorphic VT, any SVT with aberrant conduction, antidromic AV-RT with antigrade AV conduction. However, if the KRS complexes are irregular, then this may be due to atrial fibrillation, atrial flutter, or a focal atrial tachycardia with aberrant conduction, atrial flutter, atrial fibrillation or atrial flutter, or focal atrial tachycardia with anterograde conduction. It may also be a polymorphic VT, including torsade D points, maybe a ventricular fibrillation or antidromic AV and RT, due to nodoventricular or nodovascular accessory pathway. So when it comes to management, when you have a wide KRS complex tachycardia, the first thing to decide or to elicit is whether your patient is hemodynamically stable or unstable, and that will determine the pathway you take for the treatment. So this side, if the patient is hemodynamically unstable with hyperperfusion, impaired mentation, then that becomes a medical emergency, and we need to follow the ACLS guideline and then give an electrical cardioversion as soon as possible. And if you also consider sedating the patient if patient is hemodynamically unstable but conscious. And the next is when in a patient who is hemodynamically stable. So with this patient, we can take a quick history, do a quick examination. A 12-lead ECG is very important to determine the regularity or otherwise of for the rate. So if the rate is regular, then we follow this channel. Let's have to look at the KRS complexes, whether they match prior sinus rhythm. If the KRS complexes do not match prior sinus rhythm or is unknown, then we should attempt to do pharmacological termination for VT, or we sedate and consider electrical cardioversion. We also have to consider whether the patient has a known structural heart disease or unknown, or has no structural heart disease. So for patients who have structural heart disease or is not known, the treatment of choice will be IV amiodarone, IV propionamide, and IV lidocaine. And for patients who have no structural heart disease, the VT will usually be considered as idiopathic, and the treatment of choice will be either IV verapamil or diltiazem when they have a right band morphology in V1, or IV propionamide or IV lidocaine or beta blockers when the KRS complex is predominantly of left bundle branch morphology. So still on the management of VT, an ICD is recommended for patients who have been resuscitated from a VT or VF, or those who have had syncope attributable to a VT. And oral quinidine therapy can suppress recurrent VT episodes. And ablation of areas with delayed abnormal fractionated electrograms involving particularly the RV epicardium appears to reduce ventricular fibrillation recurrence in highly symptomatic patients. And again, in patients with ventricular fibrillation storm, administration of isoproterenol or quinidine can often suppress the arrhythmia. And ablation that targets the abnormal epicardial substrate or PVC triggers should be considered, as this can be life-saving. So next we look at ventricular fibrillation. This is a terminal arrhythmia which is followed by death or severe brain injury from lack of perfusion if it's not corrected within 3 to 5 minutes. It is usually characterized by irregular undulation of varying contour and amplitude without any distinct QRS complexes. So this slide shows a ventricular fibrillation. So on this side, we have normal QRS complexes, PVCs, which degenerated into ventricular fibrillation. So with the clinical features of ventricular fibrillation, they are usually rapid ventricular fibrillation and rapid ventricular flutters are the most commonly encountered in coronary artery disease with ongoing myocardial ischemia, and also polymorphic VT or monomorphic VT of any cause. In structurally normal hearts, ventricular fibrillation can be elicited by electrical shocks or precordial impacts that causes cardiac depolarization during a T wave, and this is called commotio cordis. Commotio cordis is actually when there is a strong impact on one's precordium, either with a fist or a hard object. So when this impact occurs during the time when the heart is in the depolarization stage, or which will usually correspond to the T wave, it can trigger ventricular fibrillation, and which, if not corrected within 3 to 5 minutes, can result in sudden cardiac death. There is no coordinated cardiac contractions. We usually have no blood pressure during ventricular fibrillation, and there will be absence of breath sound, heart sound, and eventually electrical activity of the heart ceases if there is no intervention. In terms of management, we usually have to follow BLS and the ACS, and it's usually recommended that asynchronous DT cardioversion using high currents of about 200 joules to 400 joules is mandatory therapy for ventricular fibrillation and ventricular flutter, as well as a pulseless VT. Cardiopulmonary resuscitation is performed or must be performed until cardioversion can be done, and CPR should resume immediately after each shock. And if the first shock is ineffective, the subsequent shock should be delivered at the maximum defibrillator output. And a bolus of intravenous amiodarone of 500 milligrams can be administered if the initial shocks are unsuccessful whilst CPR is continued. And recurrent fibrillation is usually common after initial successful shocks. So for this reason, patients should be closely monitored with immediate ability to defibrillate again as the as further evaluation seeks to identify and treat the underlying cause. So usually this will have to be managed in an ICU if available. We'll now look at ventricular flutters. So ventricular flutter is a sinusoidal tachycardia during which it is not possible to separate the QRS from the ST or T wave with certainty. And rapid ventricular flutter usually will have rates more than 280 beats per minute and can be a rapid monomorphic VT for which the etiologies are the same as for the slow monomorphic VTs as mentioned above. They can occur during acute myocardial infarction or severe metabolic derangement. It usually produces hemodynamic instability and may degenerate into ventricular fibrillation, and hence immediate defibrillation is required. Correct synchronization of the defibrillator shock to the QRS rather than the T wave is not possible, and therefore an asynchronous shock should be used. So usually in atrial flutter, we rather do defibrillation instead of DC cardioversion. So this shows an atrial flutter. Okay, so now we'll look at electrical storm. So when VT, that occurs 3 or more times within 24 hours. We have a VT that occurs more than 3 times within 24 hours. This is usually defined as electrical storm, and this is associated with difficult to control VT that are difficult to control. And ongoing electrical storm is a life-threatening emergency, and intravenous amiodarone and measures to reduce sympathetic tone should be initiated. So usually patients who have electrical storm will have increased sympathetic tone, and medications that can be used to reduce this sympathetic tone usually includes non-selective beta blockers. And some studies have shown that propranolol is more effective than metoprolol when used under these circumstances. Sedation, escalation to general anesthesia is often effective. And other means of reducing cardiac sympathetic stimulation include percutaneous stellate ganglion block and high thoracic epidural anesthesia. And patients with electrical storm often have a history of VT or have an ICD in situ and are already receiving, and also patients who are already receiving anti-arrhythmic drugs. So assessment of appropriate ICD function if they already have, and a possible pro-arrhythmic effect of their anti-arrhythmic medication should be considered if they are already on those drugs, and the decision has to be taken to continue or discontinue those medications. And if initial measures are ineffective, then emergent catheter ablation should be considered in patients with electrical storm. Okay, so these are my references. Thank you very much. So we'll end here and take questions or contributions. Thank you.
Thank you very much, Dr. Fosu, for the wonderful presentation. At this point, we'll ask for contributions and questions from colleagues on the platform. I'm just going for exams. Any questions to our presenter? Okay, so it appears either Dr. Ofosu gave a brilliant presentation and we understood or confused all of us. I think is the former. And we'll ask contributions from our consultants and fellows on the call. Dr. Adeyanju, Dr. Kopi. Okay, so it appears, Fosu, your presentation has mesmerized all of us. Do you want to clarify the localization of the focus of the PVC, since you had a bit of internet issue at that point?
Okay, so let me go back. Okay, so we can use this one. So for the localization, usually we need to look at V1, lead 1, and then the inferior leads. And by this, we are looking at the morphology of the Q wave. Sorry, the morphology of the QRS complex, whether it's more positive or more negative. So usually if it's more positive, then we know that it's going towards the lead that is being considered. And if it's going towards that lead, then means the lesion will be on the opposite side. So if you look at V1, if the lead is more positive in V1, that gives that gives a right bundle branch block morphology. It will mean that the lesion is most likely in the left ventricle. So lesion in the left ventricle will first depolarize the left ventricle before depolarizing the right ventricle, giving a right bundle branch block morphology. If in V1 is more negative, that's giving a left bundle branch block morphology. What it means is that the lesion will be in the right ventricle or the septum. And usually, if you are talking about scars, the scars usually occur, I like to occur more in the septum than in the right ventricle. So if you have the QRS complex being more negative or left bundle branch block morphology in A1, then the lesion will be in the right ventricle or the septum. And then when we come to the lead 1, so positive deflection means the impulses are going towards the particular lead. And lead 1 is on the left side. So if the QRS complex is more positive, then it means the lesion is coming from the right side. So in this case, the right ventricle or the septum, but usually most likely the septum. And if the lesion is more negative, means the waves are going away from lead 1. So in this case, it will be going away from the lateral side. So the lesion will be on the lateral side or the apex of the left ventricle. And then if we consider the inferior leads, so if the lead is more positive or upgoing, it means the waves are moving towards the inferior leads. And by that, the lesion will be more anterior. And if it's more negative, means the waves are moving away from the inferior leads. And if you're moving away from the inferior leads, then the lesion will be more towards the inferior parts of the heart. Thank you.
Thank you very much. Thank you very much, Dr. Fosu. On that note, we'll continue with the MCQs. We encourage all of us to stay on and take our parts. So I'll log off briefly and I'll join. Thank you very much. Once again, Dr. Fosu.
Sorry, Dr. Eugene.
Yeah, hello.
Yeah, good evening.
Yeah, good evening.
Yeah, that was a very beautiful, very great, brilliant presentation. But just to call our attention to the grading of the, I don't know whether the presenter didn't come across. There's loss grading, which is of clinical significance for PVCs. I think we need to pay attention. Grading like 0 to 6. I think we should check it up. I think I'll post one on the group now. And especially the management of the electrical storm, either VT or patient even on ICD having more than 3 shocks in 24 hours too could also be taken as a storm. Thank you.
Thank you very much, Dr. Stevens. Very grateful. Thank you.
Yeah.
So, are there any other questions or contributions? Let's show appreciation to our presenter. So, like I said, we'll continue with the MCQ. Just a few minutes, I'll be back. Thank you.